I would like to thank the program committee for inviting me. This is a great honor to hold the evidence-based lecture at the postgraduate course, and for a subject that in which the evidence is not that strong for the nature of the subject itself. And the evidence approach is actually what we have been doing in the last 3 years with this joint task force sponsored by European Respiratory Society and European Society of Thoracic Surgeons, which try to develop clinical guidelines on fitness for radical therapy lung cancer patients. A group of experts was formed, and each topics relevant to this subject was searched in the literature in a systematic way, and the evidences were discussed and recommendations produced and finalized in an algorithm. We started with the FEV1, PPO FEV1, which is still, unfortunately, the most widely used parameter to select patients for operation, and this is due to the most widely and currently available algorithms out in the literature, those from BTS and ACCP, which regard FEV1 and to some extent PPO FEV1 as pivotal parameters in even excluding patients from operation right away, or at least to prescribe other tests. However, recently we found that although PPO FEV1 is a good predictor of complications in patients with normal respiratory function, it is not as such good in patients with airflow limitation. And this was subsequently confirmed by these other papers in chest. They operated on patients with a very low FEV1 with a very acceptable mortality rate of only 1%. And this is probably due to the so-called lung volume reduction effect, which has been discussed previously, and which applies not only in end-stage emphysema patients, the typical candidates for lung volume reduction surgery, but also in those patients with lung cancer and less severe degrees of COPD, typical candidates for lobectomy in our routine daily practice. And in fact, a number of papers have been published showing a minimal loss or even an improvement in FEV1 after lobectomy in these patients, questioning the traditional operability criteria, mostly based on PPO FEV1. And we also found that this lung volume reduction effect is not something that takes place very late in the course of the postoperative course of this patient, but it can take place very early. For example, at discharge, we found that 17% of patients with the airflow limitation may actually improve their FEV1 compared to preoperative values. And even earlier, the difference between preoperative FEV1 and the FEV1 measured on the first postoperative day is much lower in patients with COPD. It is directly proportional to COPD index. You see here that following the course of patients after lobectomy, patients with COPD have a much lower decrease in FEV1 compared with patients with COPD at discharge 1 month and 3 months. At 3 months, 27% of COPD patients actually improve FEV1 after lobectomy. COPD is defined as an FEV1 less than 80% and FEV1 to FEVC ratio below 0.7. The other problem, of course, stemming from this concept is that PPO FEV1 is less accurate in patients with low FEV1. And this, of course, creates problems when using this parameter for selecting patients for operation. And the other big problem is that PPO-FEV1 largely overestimate the actual FEV1 in the first or second postoperative day. So the FEV1 measured the day following the operation is actually 30% lower than the PPO-FEV1 as traditionally calculated. And this is probably the reason why the FEV1 measure on the first day is a much better predictor of complication than PPO-FEV1 as assessed by a regression tree analysis. So the evidence-based recommendation of the task force were that PPO-FEV1 should not be used alone to select patients with lung cancer for lung resection because it tends to underestimate the functional loss in the early postoperative phase, and it is not a reliable predictor of complication, particularly in COPD patients. The other issue is DLCO. DLCO has been shown to be a good predictor of complication after lung resection in the 80s, and similar to PPO-FEV1, even PPO-DLCO was shown to have a strong independent effect on pulmonary morbidity and mortality by Ferguson and colleagues in the mid-90s. They found that patients with a PPO-DLCO below 40% had the mortality rate as high as 20% in their series. This was subsequently confirmed by several studies like this from Santini and colleagues. They found an inverse linear relationship between PPO-DLCO and occurrence of pulmonary morbidity. So if DLCO is such a reliable predictor of surgical outcomes, why it is not assessed so regularly in our clinical practice? We know from the ESTS and STS registries that the compliance in measuring DLCO for lung resection, before lung resection, is about 50-60%. And most of this is due to, again, to the currently available algorithms which recommend to measure DLCO only in patients with low FEV1, with reduced FEV1. And this is based on the wrong assumption that FEV1 and DLCO are highly correlated, which is not the case. As you see here, the correlation coefficients between FEV1 and DLCO are consistently very low in every subset of patients. And this is not surprising, as FEV1 and DLCO measure two completely different aspects of the pulmonary function. We know that there are at least 40% of patients with normal FEV1 with a DLCO below 80%. So there is no clear justification to reserve DLCO measurements only to patients with a reduced FEV1. And in fact, you see here there is no correlation at all between DLCO and FEV1 to FEVC ratio as well. We know, in fact, that a reduced PPO-DLCO is a good predictor of cardiopulmonary morbidity, even in patients without airflow limitation, with normal FEV1. And this was confirmed by Ferguson and colleagues in more recent studies. They found that PPO-DLCO was an independent predictor of morbidity and mortality, either in patients with COPD and in those without COPD. You see the effect of a reduced PPO-DLCO exerts equally on COPD patients and non-COPD patients. So the recommendations are that DLCO should be routinely measured, systematically measured in all lung resection candidates, regardless of whether the spirometry is abnormal. But certainly we try to find a more global test, a test that is capable to assess the fitness of the patients in a more global way, to assess the oxygen transport system in its entirety, and to precisely identify the possible deficits that may be amenable to correction to improve the status of the patients before operation. And these are certainly the exercise tests which are increasingly used in our specialty. There are several types of exercise which we can use before operation, the so-called low technology test, like the walking test or start climbing test. and the high-tech tests, those directly measuring the expired gases during incremental exercise. About the 6-minute walking test, there are conflicting evidences in the literature in our setting, in our specialty. Some papers didn't find this test predictive of complications, some others predictive of mortality, but only in a specific subset of patients. Certainly, shuttle walk test is more reproducible, that 6-minute walking test, and it has been estimated by regression that 25 shuttles corresponds to a VO2 max of 10. And for this reason, this 25 cutoff value has been suggested by BTS as a selection criteria for operation. However, recent papers have shown that shuttle walk test tends to underestimate the exercise capacity, particularly in patients with low VO2. And for this reason, should not be used alone to exclude patients for operation. Star climbing test is another widely used and familiar test. It has several advantages. It's quite familiar for the patients, economic, like all these low technology tests. It is rapid, non-invasive, but at the same time highly stressful for the patients who are really pushed to reach a visible objective represented by the next landing. And this was the first experience published in CHEST. On 160 patients, we found after logistic regression analysis that the altitude climbed at preoperative star climbing test remained the only significant predictor of morbidity. The series was then expanded up to 640 lobectomy and pneumonectomy. And this is a breakdown of patients. You see 40% were elderly patients. Almost half of the patients had some form of cardiac comorbidity. To give you an idea, the average duration of the test is a little less than 2 minutes, so very rapid, and the average altitude reached by the patients was 19 meters. And in this large series, we didn't observe any significant complication related to the exercise. And compared to patients climbing more than 22 meters, those not reaching 12 meters had a 2.5 higher rate of cardiopulmonary morbidity, a 3-fold higher rate of cardiovascular morbidity, and 13% mortality rate versus just 1%. You see, even after regression analysis, the altitude star climbing test remained an independent, reliable predictor of morbidity and mortality, independent of age, extent of resection, presence of cardiac comorbidity, and PPO FEV1. Limited to those patients with prohibitive PPO FEV1 or PPO DLCO, these tests stratify very well the mortality rates. Even in these high-risk patients, those climbing more than 22 meters had no mortality, but those not reaching 12 had a very high mortality rate. These are the evidence-based recommendation of the task force, limited to low-tech tests. Shuttle walk test should not be used alone to select patients for operation. However, it could be used as a screening test. But then patients walking less than 400 meters, since they may have a peak VO2 below 15, they should be referred to a more sophisticated exercise test like CPET. Star climbing tests should be used as a first-line screening test to select those patients that can undergo safely to operation. But these are those performing very well on the stairs. For all the others, even these patients should be referred to a formal cardiopulmonary exercise test in order to optimize their perioperative management. And high-tech exercise tests remain, of course, the gold standard in our specialty for preoperative evaluation. Since they are performed in a control environment with continuous monitoring of various parameters, and they are easily reproducible in different settings. And although peak VO2 is certainly the most important parameter to consider for preoperative evaluation, CPET provides a number of other information that can precisely identify the possible deficit in the oxygen transport system. And this can permit to institute treatments or management to optimize the perioperative course of these patients. and reduce, of course, surgical risk. After several papers published in the 80s, a small series, this was the largest series published in the 90s by the group of Bolliger. They very elegantly demonstrated the importance of the VO2 max in predicting cardiopulmonary complications in lung resection candidates, particularly when expressed as percentage of predicted. They were able to demonstrate that the probability of non-having complication if the patient had a VO2 greater than 75% of predicted was higher than 90%. On the other hand, there was a risk of as high as 90% of developing complication if the patient had a VO2 below 40%. And the same group, but in a different series of patients, confirmed these results. They were able to combine the extent of resection and the VO2 max value to predict the surgical risk. For example, a patient with a VO2 below 50% undergoing pneumonectomy may have a risk as high as 86% of complications. And this is our series published this year in Chest. It is a large series on 200 major lung resection. It's interesting to notice the breakdown of patients. 43% of patients had a VO2 below 15 milliliter per kilo, which is the operability cutoff proposed by BTS, if you remember. Had we accepted this threshold, we would not have operated on almost half of our patients. And we think that this pie reflects the case mix of patients presenting nowadays to a modern thoracic surgery. Patients are elderly, patients are quite unfit with underlying comorbidity, cardiac and pulmonary. So we have to accept a certain this low level of VO2. But on the other hand, you see how well the VO2 stratified the risk. There was an increase in respiratory complications where the VO2 was below 12 and below 50% of predicted. And the same applied for mortality, steep increase in mortality when the VO2 is below 12 and below 50% of predicted. You see here the stratification of VO2 and occurrence of complications. A patient with a VO2 below 12 may have a risk of mortality as high as 13%, so very high. But on the other hand, a VO2 greater than 20 had no mortality and a very low morbidity rate. The problem is only 13% of our patients had a VO2 greater than 20. And we operated on almost more than 100 patients with a VO2 below 15, and we had 4 deaths, and all deaths occur in patients with a VO2 below 12. So we now regard a 12 milliliter per kilo per minute a high-risk threshold, and we refer these patients to preoperative rehabilitation. We try to optimize their cardiopulmonary status and plan and advanced care management in their postoperative course. The recommendation are that peak VO2 is certainly the best parameter for assessing preoperative evaluation. It should be regarded, of course, the most important measure of exercise capacity. We will come back to the cutoff when we're talking about the algorithm. We try then to synthesize all these evidences in an algorithm, and there are a series of algorithms out in the literature. This is actually the only algorithm published in the late 90s which has been prospectively validated. The authors found that applying this algorithm emphasizing the cardiac evaluation, the systematic DLC or measurement exercise test, they had a reduction in mortality and morbidity rate compared to an historical series. And this algorithm has stood the test of time for a decade or so until a couple of studies appear in the literature questioning not much the structure of the algorithm but the cutoffs. in the algorithms. Such these studies, like this study from the cancer leukemia group B, they found that 58 patients who would have been deemed inoperable by the previous algorithm were operated with the same morbidity and mortality of patients who were deemed operable by the previous algorithm. And so they concluded that presumably the cutoffs of the algorithms, particularly the PPO-FEV1, PPO-DLCO, were too conservative, erring on the side of safety. And we found similar results. You see that by applying the cutoffs of the old algorithm, we had more than 10 patients that were operated basically without any mortality. So we try to maintain the structure of the algorithm and change, reducing the, lowering the cutoffs. So this is the algorithm proposed by the ERS and ESTS, now published jointly on the European Respiratory Journal and European Journal of Cardiothoracic Surgery in the July issue. And you see there is the important points are there is a preliminary cardiac assessment. And if you go to the original paper, you see also there is an algorithm, a cardiac algorithm. When the patients are regarded as low cardiac risk or treated, they proceed to pulmonary evaluation. And now the novelty compared to AACP, ACCP or BTS are the systematic measurement of DLCO, which is recommended in all patients, and the use of percentage of predicted values. So we definitely eliminated the confounding factor of absolute values for FEV1 and DLCO. If patients have no cardiac risk with both FEV1 and DLCO greater than 80%, they can proceed to resection as planned up to pneumonectomy. If either one, FEV1 or DLCO or both, are below 80%, and this is another important point, then they have to perform an exercise test. So exercise test has been moved very high in the algorithm and conceptually precede the split lung function. Again, if the patients have a very good exercise test, so a VO2 greater than 75% or greater than 20, they can proceed up to pneumonectomy. On the other hand, if the patients have a VO2 below 35% or below 10, usually lobectomy or pneumonectomy are not recommended, and we advise for other surgical options like minor resection, segmentectomy whenever technically or oncologically feasible, or other treatment like radiochemotherapy, radiofrequency ablation, and so on. For all patients having this value in between 35, 75, or 10, 20, then we take into consideration split lung function. Of course, split lung function are calculated, at the same time you perform spirometry and the LCO, but conceptually, we advise to take them into consideration after the exercise test. And you see here we lowered the cutoffs from 40 to 30%. So if both PPO, FEV1 and PPO DLCO are above 30%, the patients can proceed to the planned resection. If at least one of PPO, FEV1 or PPO DLCO is below 30% or both, then you can take into consideration PPO VO2 max, which is a parameter for which the evidence is not so strong like PPO, FEV1 and PPO DLCO, but it is calculated in the same manner as PPO, FEV1. Even in this case, if the patients have a PPO VO2 below 10 or below 35, lobectomy or pneumonectomy are usually not recommended. We also added, a statement that in cases where a CPET lab, a cycloergometry or treadmill is not readily available, you have at least to try to make this patient on the stairs and perform, a low-tech test preferably stair climbing test, but also shuttle wall test as a screening test. And for all the patients performing suboptimally to a low-tech test, they need to be referred to CPET for a formal evaluation. Thank you very much for your attention.
Thank you very much for the nice and very clear presentation. Are there questions? Please introduce yourself with your name and the institution, and then we know who we're talking to. Walter?
Alex, very nice work. I have 2 points. The first is the CO diffusion capacity. Many patients we see, they are a sports person and they are fit and so on. So why shall we do CO diffusion capacity? I mean, if it's a recommendation to everybody, it's a recommendation to everybody. That's first point one. And the other point is, if FE1 and CO diffusion capacity is below 80%, I'm not sure that each center will follow your recommendation to go to exercise testing and measure peak VO2. The majority, they will look at the CT scan and say the lobe we take out is anyway obstructed and so on, before it will use exercise testing. So if you could comment on these 2 points.
Yeah, these are very controversial points, and the message we try to convey to the majority of thoracic surgical units was a message of the importance of the LCO. Of course, you know better than me that the algorithm are a simplification of the real life, and we always have patients, falling out of the algorithm on, both ends. So patients very, unfit that, can, try to perform a lobectomy for several reasons, and patients, well fit, that you wouldn't perform a DLCO. But of course, these are guidelines papers or recommendation papers based on evidences, and trying to make single exceptions for every case is maybe deceiving also in the conveying of the message. And for the other points, we recognize that exercise tests may be not readily available in all centers. Before that, we perform a survey to our membership, and surprisingly, most of the centers responded that in 80% of cases they have a CPET lab available. But on the other hand, they perform CPET in less than 20% of patients. So there is some discrepancies in this, and maybe cultural, maybe a lack of knowledge of the importance of this test. And as a buffering measure, we introduced the concept of low technology test. For us, it's very important that the concept of exercise gradually get into the mind of surgeons or all the people involved in the preoperative evaluation. And at least, if you don't have a CPET lab, if you don't want to perform right away a VO2 peak estimation, at least make the patients, put the patient on the stairs and see how it works, or shuttle wall test, because it is a very important information. It can disclose, the deficits that they could probably went unnoticed by just using spirometry or even the LCO.
Yes, please, in the back.
John Handy. I'm not sure if I can make this work. John Handy, Portland, Oregon. Very impressive summary, Dr. Brunelli. And we, as a specialty, are understandably focused on morbidity and mortality, but that's not the patient's question when we speak to them in the clinic. They really want to know about functional outcomes and quality of life. And since you've done such an extensive review of the literature, can you make any comments about that with regard to the extent of resection and physiologic determination?
Yeah. If you go to the original paper, there is also a paragraph on functional and quality, or residual functional and quality of life. And of course, as you know, the evidences are not that strong, particularly on quality of life. But for example, there is no clear objective parameter which can predict postoperative quality of life, which is by definition a subjective measure, maybe with the exception of DLCO. Some papers a couple of papers have shown that DLCO may be linked to residual quality of life. And we know, for example, that pneumonectomy is consistently reported as an adverse operation for residual quality of life. We cannot give a recommendation on quality of life with exception to use specific ad hoc instruments to assess quality of life and to gather information on these patients. And of course, patients' reported information like quality of life will be in the future even more important, even to factor in the equation when to decide to operate a patient, patient's expectation and quality of life.
Thank you. Doug?
Doug Wood from Seattle, just up the road from Portland, Oregon. My colleague, we're almost neighbors. Alex, a great presentation, and it's always difficult to try to digest this material into good evidence-based recommendations. My biggest concern is the elevation of exercise testing almost to the top of the algorithm. And the reason is practical, and it's twofold. One is technology. So yes, you've pointed out that it's available, but being available or present in one center doesn't mean that it should be done. Because it still is a high technology test. It's a very expensive test. In the United States, it overshadows every other test in this algorithm in terms of cost by an order of magnitude. And access is more difficult also because it's a relatively labor-intensive test. So you can get a spirometry in 5 minutes just by asking somebody to go get it. This, in our hospital anyway, is a potentially month process of getting on the schedule for exercise testing. Even though we have it, it's available. I could have that patient operated on and home by the time that they would be able to have exercise testing. So I'm concerned about the practical nature of this because I recognize that exercise testing probably provides the most rigorous assessment of somebody being operable or not. Yet I would argue that 95% of the time, we as thoracic surgeons can look at other simpler tests combined with functional status and kind of practical things like their exercise activity outside of the hospital and make these assessments without needing to wait for the time of the exercise testing or spend the money.
Yeah, that was the major concern, but based also on my personal experience, we did a lot of studies on stair climbing test before to progress to CPET, and we almost came to the point that to not looking at spirometry anymore, just looking at the patients, climbing the stairs. So if you don't want to perform a formal CPET, at least, put the patients on the stairs. Sometimes what the patients tell you about, his or her personal exercise activity is not quite accurate. You sometimes realize that, the patients tell you, okay, I have 2 flights of stairs home, and I can climb easily, but then you put the patients on the stair, you see that they saturate, and there is something wrong, So I agree with you, it can be difficult to, logistically difficult to, apply in all centers, and as a matter of fact, we are trying to validate this algorithm, the feasibility of this algorithm to see, whether this is the case or not, in a prospective way in some centers.
But maybe logically you do the right thing, you put exercise testing very early, but in real life, I think if you don't include imaging and also split function is not only the only information you have from perfusion ventilation scintigraphy, if you have an upper lobe tumor and you don't have any signal in the ventilation perfusion scintigraphy, it's a much more important information than you get from exercise testing. So you have a logical, good scheme, algorithm, but it doesn't really apply to real life, and that, I think that's a bit the problem.
Just hold on a minute. We're well past time. And this is an interesting discussion, but you're beginning to go over it a couple of times. What I'd like you to do is, Eric and David, put your questions succinctly, and then, Alex, if you sort of round up in response to their questions and finalise. So put your question, and then David and...
Eric Lim from the Brompton. Hi, Alex. Great presentation. Congratulations. My question is, I have to apologize for this because we've gone through the whole evidence base as well in the British guidelines. And I'm going to put to you that VO2 max is the least reliable test. It should not be regarded as the gold standard. And I'm going to give you 3 reasons why. One, they use composite measures. So if many of the composite measures included outcomes like lobar atelectasis, high PCO2, and readmission to ITU, many patients wouldn't consider that to be prohibitions for surgery. So if you say less than 10 don't have surgery, many patients may not agree. Secondly, it doesn't apply to mortality. It can't, because the studies have ranged from a sample size of 8 to 160. And with a mortality rate of 2.6%, none of the studies are powered to accurately inform us about mortality. And then thirdly, arbitrary cutoff points of 10, 15 are not valid. And the reason for that is, if you have a 0 value in a sample size of 10, the uncertainty of the confidence interval ranges from 0 to 30%. And because all the studies are underpowered, arbitrary drawing a cutoff point, high or low, or using composite outcomes, causes a whole mess for VO2 max. And as a result, I don't think it can be interpreted at all. I'm sorry for that.
David, what's your comments? A bit totalitarian view there.
In 2001, we wrote a paper and coined the phrase lobar volume reduction surgery. And this is what you're talking about, is doing volume reduction surgery, because these people are COPD patients. You haven't included any measurement of hyperinflation, which is a selection criteria for lung volume reduction, and that is why they can tolerate the operation, because they have the relief of hyperinflation. And you haven't mentioned heterogeneity, which is what, again, is a selection criteria for volume reduction surgery. And if you look at the net selection criteria, VO2 max is not in there.
Okay, and a succinct answer?
Yeah.
We take the point.
The issue is, this is an evidence-based paper, you know, and of course, yeah, and presumably the algorithm, the figure itself, is deceiving in one way, you know, of the information provided in the guidelines, but we had to summarize some way. And about the VO2, I slightly, you know, disagree with Eric. And we tested our patients. You know, we published in, it was a very large series, probably the largest, on more than 200 lobectomy or pneumonectomy. These patients below 12, not below 10, below 12, we had very high mortality rates. And we are talking about mortality rates. I agree with you that mortality in our field, fortunately, is not such a powered endpoint. And this is applicable also to other endpoints. And I don't want to go through all the problems with endpoints here. But, you know, please consider that this is a guideline paper. The algorithm should be interpreted with granus salis. You know, we are all thoracic surgeons, experienced. Of course, we consider heterogeneity. We all look at the CT scan, and you know,
yeah. Well,
this is my invitation. You know, the algorithm is not the Bible.
No. Well, I think
algorithm is a guide.
Right. I think it's a good moment to close, because the points you make are absolutely fine. We are clinicians and we make judgments. We take many factors into account. One cut-off is clearly nonsense. Life is not like that. And we use all the information available in the interests of our patients. So, you know, it's very good and not easily broken down into simple rules.
Many things are correct, but it's not applicable.
Are these drugs commercially available?
Alors, salut, salut. Non, parapluie. Jérôme, tu connais Jérôme? Un peu mieux, là. J'étais bien. Absolutely.
No, I agree. They seem that way around too.
I need to. Of course, I am open to modify.